while it may be considered rare, and pain management physicians tend to see this more because of the type of patients that we tend to see in general, I'd like to bring up the idea that opioids are not considered first-line treatment for these patients. There may be a bit of a knee-jerk reaction to starting a patient who's in pain on an opioid, but the literature will suggest that that's not the best option, nor is it especially the first-line treatment option for these patients. We tend to use agents such as gabapentin, anticonvulsants, gabapentin or Lyrica, pregabalin. At Washington University, we use a medication called low-dose naltrexone, which is very interesting. Naltrexone's been around for a long time, and it's used to treat, historically, it's used to treat patients who have an opioid abuse issue, right, at 50 milligrams or 100 milligrams. Well, it turns out research from Stanford over the last 7 or 8 years shows that low-dose naltrexone can actually be a potential glial cell modifier. And in those patients that have CRPS, we know that there's glial cell activation, and that as long as that's going, it may be very difficult to control their pain. We also use, as the mainstay of our treatment, a specific kind of physical therapy program called graded motor imagery. And it's not very intense. There's only 3 sessions. So it's something that is very capable for most patients to do. It's not a very time-intensive therapy. And it is a sequential process of cortical reorganization. I told you that there's something happening in the central nervous system with these patients. So the first time that they go to graded motor imagery, they go through what we call laterality. And laterality for a lot of these patients may be like a kindergarten exercise. So they get these flashcards of people holding hands in different positions or feet in different positions. And they're asked, is it the left or the right? And so they have to go as fast as they can. And you'd be surprised at how much they get wrong. But some of them look at this and say, what's the point? This is ridiculous. Dr. Boutros, I don't understand what you're doing here. But then I tell them, hang in there because it'll really manifest itself at the end. So what it does is it's priming at that point, the brain. And then the second step is what we call explicit motor imagery. So what that is basically is, let's say the right hand is affected. They'll show a video of somebody using their right hand to use a utensil to eat. Or they'll show the person using their right hand to dribble a basketball. And then they'll ask them to close their eyes and imagine themselves doing that. And just doing that, just imagining themselves using their extremity, will set off a pain syndrome. And will, in fact, for those patients who have signs of CRPS, they may get increased swelling right then and there and changes in color. And so that's that second stage of sort of activation. And then the third stage is what we call mirror therapy. And that's where they'll put a mirror in between the affected and the unaffected extremity. So what they're essentially doing is that they're covering the affected extremity so they can't see the affected arm or leg, for example. And so if, let's say, using the same example, the right arm is affected and now it's behind this mirror or a mirror box. And they'll say, okay, Mike, I want you to move your right hand. Now you're not going to move your real right hand. You're going to move your left hand. But the brain is sensing, is seeing the mirror and is looking and thinking that it's the right hand. And the left hand is not affected. It's not problematic. So essentially what it's doing is it's reorganizing the brain into basically tricking it back into normalcy. And it's this idea of neuroplasticity. And it's that stage where even the most doubtful patients will come back and tell me, Dr. Boutros, I can't believe it. That was really what put it together. And they'll take what they learn and they'll do it at home. And even at work, they'll use their mirror box. And a lot of them will tell me that their coworkers will look at the affected arm that they can't see behind the mirror. And they'll just see it changing, color and swell and everything. And what essentially it's doing is it's trying to reorganize everything. And we've had amazing success with graded motor imagery. Again, it's not medication-based. It's not necessarily interventional-based. It's low cost, right? I don't need virtual reality for this. And we have shown a success rate of close to 70% improvement. And we look at this in terms of functional scores, whether we're looking at low extremity functioning scale or the quick dash for upper extremity. We look about in terms of reduction in opioid use. So at Washington University, we're about ready to publish this paper. About 92 patients or so have come through our program over the last couple of years. And of the patients that came in on opioids, all it took was those 3 sessions. And so those 3 sessions is about 6 weeks, right? And some of these patients have had symptoms for several years and have been on opioids for years. We have had almost a 70% of patients come off of opioids completely through the program. And of the remaining 30% or so, there's a significant reduction in the amount of opioids that they need, and they're functioning better. So it's interesting because, again, we're looking at things from a slightly different angle. I mean, in the past, we always treated it as a peripheral problem, right? The arm is the problem, we're doing sympathetic blocks, we're giving all these medications, and we're only meeting success halfway. But this is a very interesting way of treating what we classically thought was a peripheral problem. It is the same process that we use for phantom limb pain. And so when I was over at Johns Hopkins, they would use graded motor imagery for phantom limb pain at Walter Reed, for example, and it's been around for a very long time. So it's interesting because the research really came out from Australia using that same approach, graded motor imagery, to treat CRPS patients. And they looked at a different sequences to treating the CRPS. So I talked about how we talked about laterality and then explicit motor imagery and then mirror therapy. And they tried to mix it up and see if there were differences. And in fact, using the process that I described earlier is actually the best way to show improvement in these patients. So it actually does matter what you do first and in what order.